Hello, and welcome to the GRACE podcast series. My name is Denise Brock, and I am the Operations Director for the Global Resource for Advancing Cancer Education, or GRACE. In this podcast series, we interview patients, advocates, and healthcare professionals to provide the most updated information for our community and to highlight important issues facing those dealing with a cancer diagnosis. We hope you find this information valuable. For questions or comments, please visit us at cancergrace.org.
Let's turn to the situation of someone who has progression after 2.5 years on Alecensa, alectinib. They have an ALK rearrangement, they tolerated it well, but at this point they have multiple areas of progression, bone metastases and liver, say. What is your approach? Do you biopsy that in all cases? Do you think that that is a particularly high yield intervention? And what is your general go-to approach after that if there isn't some clear indication of what to do based on the biopsy? Suki, can I start with you there?
Yeah, absolutely. So I think that my approach would be to biopsy with especially such multifocal progression. And that biopsy is sort of helpful, I think, in two ways. One way is we know that, unfortunately, somehow our lung adenocarcinoma type tumors can change into a totally different kind of tumor, and that looks completely different under the microscope and may have sort of implications on what we use for treatment next. And that, I think, has been shown, including squamous transformation. It's another non-small cell lung cancer type, and also small cell lung cancer transformation, which is, of course, we need to know about because the treatments are very different. So that's one way I think it's helpful, just to confirm that the tumor type looks the same under the microscope. I think the other important aspect of it is try to sort of understand why this resistance happened. And we can at least do that to some degree based on some of the clinically available next generation sequencing testing we have available, either in-house, like we have internal testing at Stanford, but there's also, of course, commercial assays. And that may give us a sense, is there a mutation, another mutation that developed in ALK that caused this resistance? There's some sort of guidelines in terms of what treatments we can do next based on that, although it's not 100%. It's more of like a guidance in terms of what we should do next based on the resistance mutation profile. And so I think those are the two ways that it can be helpful.
Mm-hmm. Jonathan.
So I agree with Suki. I generally do biopsy. I start with the plasma first approach because you can draw a tube of blood in clinic that day and hopefully get an answer in a week or two. I also think, it helps determine treatment in certain situations. I think, there's been published data by Dr. Shaw and colleagues that looked at circulating tumor DNA, and if they found an on-target ALK resistance mutation. So the alectinib is being outwitted by the cancer by new ALK resistance mechanism within the ALK gene, compared with not detecting that. On average, lorlatinib, which is approved, the response rate's about a third of patients. But if you detect that ALK resistance mutation in plasma, it was about 69% that had a very good tumor shrinkage, whereas it was only about 27% when that wasn't present. So I think that's one thing that's informative, because lorlatinib, which is a third generation ALK inhibitor, is now approved. And so with response, good tumor shrinkage being about a third of patients overall in that situation, but then if you get an on-target resistance being almost 70%, that's something noteworthy. And then if I don't get that, I do generally look for a tissue biopsy, and then once again to look for those on-target resistance mutations where we can know, looking at different ALK inhibitors, what mutation may be more sensitive to others. And also if there's other mechanisms that's not just ALK, but something we call bypass track, where the cancer outwits the drug by running around ALK through another protein, for example, there's one called MET, where crizotinib, which is the first generation ALK inhibitor, also is a MET inhibitor, was initially developed as a MET inhibitor. We have clinical trials like one developed by my colleague Colin Blakely at UCSF with adding a MEK inhibitor, trametinib to ceritinib. So that could all be informative. And but what's approved now is lorlatinib as a next generation ALK inhibitor. But this is the way I think about how we treat ALK lung cancer. And, chemotherapy can be very effective in these patients too. If they haven't had chemotherapy, there's a sense that pemetrexed, also called Alimta, can be especially effective. And often we give that with carboplatin and other drugs. So that's the way about how I think of treating these patients.
So let me follow up. Suki, would lorlatinib generally be your next approach? Let's say that you didn't get an informative result from the biopsy. Would you, as Jonathan mentioned, you could consider chemo, you could consider lorlatinib, there may be other choices. Jonathan, maybe you could plant a flag and say, would you favor lorlatinib generally over chemo in this setting, or after alectinib, or which would you prefer?
The response rates overall are fairly comparable. If you look at like pemetrexed or lorlatinib, generally patients prefer taking a pill drug. It's got good CNS activity, so generally favor lorlatinib, but chemotherapy is also a good option.
And in truth, it's not necessarily either or forever. It's just what next. Suki, what's your thought?
Yeah, so I think there's still a little bit of a question with all the available ALK inhibitors.
We haven't had any of these tested directly. It's all inference.
Correct. So essentially, I think lorlatinib is a great drug in the space is because we do at least have some data from a clinical trial setting showing that for a proportion of patients who have received alectinib before, lorlatinib can work, probably in around 30% of patients, like Dr. Riess said. However, any particular drug has its scope of toxicity, and lorlatinib, I think, it has a little bit of a unique toxicity profile that if physicians are going to this drug next should just be aware of, because it can really impact our patients' quality of life, particularly some of the sort of cognitive toxicities, not feeling quite right, some depression, mood disorders that can occur with the drug that really do seem to be dose dependent. Cholesterol, high triglycerides, swelling. So it has a little bit of a unique side effect profile that I think, definitely has a purpose, but we just need to be aware of the side effects so we can get at them early. The one thing I do want to emphasize is I think it's important of what's going on in the brain at the time of progression on Alcenza, because like Dr. Riess, we have lorlatinib, we potentially have other targeted therapies, but we don't quite know where they fit. But we also have chemotherapy where pemetrexed can work for super long time in some of these patients with ALK. And I think if there's also both body progression and brain progression, that I would favor doing lorlatinib because of the activity in the brain.
Yeah. Okay.
And I would just highlight for the audience, there's a great article in the Oncologist on how to manage side effects with lorlatinib. So I'd refer folks there. Take a look.
Good to know. I would just take a step back and devil's advocate say that though I appreciate the value of doing a repeat biopsy to see what's going on, at this point we don't have good evidence to say that it has a big impact, certainly outside of academic settings where the options are pretty limited. It's not a standard of care right now that has a clear proven benefit. And just along the lines of what Alice Shaw and colleagues saw at Mass General with the different profiles and the probability of response to lorlatinib, the benefit of lorlatinib, even in the less favorable, is high enough that it's still a good choice. So it gets to the question of you could do this, but all roads lead to trying lorlatinib, maybe next or not.
I would just comment one small. It's a minority of patients, but sometimes we see early progression where it's more likely there's that squamous type cell transformation that's been described small cell, probably less commonly in EGFR, which even in EGFR is very uncommon. And then some of these bypass tracks like MET and so forth. So there are
in
some
truth,
places that,
if we don't look, we won't find.
Yeah,
That's for
yeah.
sure.
Thank you again for joining us. This podcast was made possible by the generosity of sponsorship from our friends at Lilly, Novartis, Takeda, AstraZeneca, and Exelixis. Please like and follow us on Facebook and Twitter. Send us feedback, share your story, donate and visit us for more information at cancergrace.org. Thank you for listening.